Hey everyone, this is Lauren Perez with the Texas City Lamarck Chamber of Commerce. We are super excited to get one of these presentations done for our young professionals of the mainland. We are super excited to actually partner with Houston Methodist. Our members are out there in Nassau Bay, and we are super excited. We are only getting older, which is the hard truth that we face every single day. And as young professionals, we're finding out new aches and pains and different things that we have to go through. So I'm going to hand it over to the Houston Methodist team, and we can go ahead and get started.
All right. Thank you so much, Lauren. My name is Heather Colementor, and I am actually the physician that started here. I'm doing interventional pain management. So I kind of want to first just give you a little background about me. I'm a board certified anesthesiologist. So I was actually practicing anesthesia for 10 years, and then recently made the switch over to chronic pain, and then also doing interventional pain management. So this area is very dear and close to my heart. I actually went to University of Texas Medical Branch for medical school. Did my anesthesia there also, and then was out here practicing at St. John's for quite a long time. It's actually Methodist now, so I was even there before it was Methodist. And then I went back to UTMB for my interventional pain management. Some other things that I've done too is I did a fellowship in integrative medicine at the University of Arizona, and that was with Dr. Weil, and that's kind of also looking at other areas of pain, such as using yoga, meditation. You learn the different Chinese medicine, also looking into nutrition, and also looking at different supplements that maybe we can use to help with chronic pain. My hometown is, a little to the west, Katy, Texas, so I've been in this area for quite a while. And I just kind of want to talk to you a little bit about chronic pain and some of the things that we could do. If we could go to the next slide. So I think this is really interesting. This is the definition of pain that was recently published by the International Pain Society. It's pain is an unpleasant sensory and emotional experience, and it's associated with actual or potential tissue damage, which I think is quite interesting. Before we were just treating pain that we thought, mechanical pain, but now we're really starting to see that how important the emotional component is to it. Next slide. So one of the things we want to look at, what is acute pain, what is versus chronic pain? So definition of that is chronic pain is it extends beyond the expected period of healing, which is usually about 2 months. For us, pain is a normal sensation. It's really your body trying to tell you to stop. It's a protective mechanism. So it's a normal sensation that's triggered in the nervous system to alert you that you could be hurting yourself and that you need to take care of yourself. Or it's caused by such things as that we have surgery or some type of traumatic injury. Next slide. So here's the thing, it's been interesting to see with chronic pain, it's now, we classify it as a disease. Chronic pain, it outlives its original cause and usually worsens over time. And it really can take over on like a puzzling part of your life, which is really interesting as we're seeing now with functional MRIs, that it can change the way that your brain is actually functioning or looks. We can see different parts of the areas that are being stimulated because of patients in chronic pain. So it can even affect your cognition and the way that you move about with your friends and family. Next slide. So here, this is one of the things that we really, as with chronic pain, is that you end up having pain. It may be acute, but then as it moves past those, 2 months, patients will start having anxiety about that pain. They have that pain that's signaling from the tissue damage that they have, but then the brain naturally wants to focus on that problem. So the brain begins to really kind of hone in, and then that can make changes in the nervous system. And the nervous system is also the peripheral nerves. And we can also see it in the brain, as what we had talked about with the functional MRIs, which then can actually make a patient have even more pain. And then with that more pain becomes more anxiety, not moving, less function, not going out with friends and family. And then we see more changes, and then we begin to have this pain cycle that we need to figure out a way how we can break that. And one of those ways is, what I do with interventional pain, but it's a very multimodal approach that we need to take to be able to kind of break that cycle. If we can, next slide. So I think this is interesting, how important it is for us to really look and how important pain is to society. We can see actually number 1 and number 2 reasons for disability in the U.S. society is arthritis and back pain and spine problems. Next slide. And as all of us have heard, what we are seeing right now is with chronic pain, we saw the amount of opioids that were prescribed per person is 3 times higher in 2015 than in 1999. And as we see is taking opioids for long periods of time, there's higher doses, there's an increased risk for addiction, overdose, and even death, and also just seeing the decrease in quality of life. Next slide. So kind of interventional pain, the thing that I think is really important is, and if I could only stress, is that we really have to start looking at chronic pain in a multimodal approach. For me, with interventional pain, what we can do is there's certain types of injections, and I'm really happy for us to we can talk about these in detail on, different things that I can do, but, this is kind of helping with pain. But then we also have to look at the emotional aspect. We also have to look at the mechanical aspect, which is also physical therapy. But some of the things that I can do is what's called an epidural steroid injection. And that's really us getting into the area around the nerves of the spine and kind of bathing those nerves with some steroids to hopefully help decrease that inflammation process. And then hopefully with that, then I can really get you into physical therapy and working on some of those mechanical problems that could be causing the chronic pain. Another one that we can do is called a diagnostic block, and that's looking at the joints of the back, that we can go in, we can look at a certain nerve, it's called the medial branched nerve, that provides sensation to the joints in the back. And we can go in there and we can do a little injection to see if that's the source of the pain. And then what we can do after that is we move into something called radiofrequency ablation. And hopefully that gives a long-term relief. With that radiofrequency ablation, we can go in, the myelin outside of the sheath of the nerves, we kind of ablate that with a radio frequency. So then the signal or the sensation doesn't make it to the brain that those joints are aching or hurting. There's other things that we can do too that are a little more aggressive. There's certain things called neuromodulation, and that's some really interesting things that have been happening, that what we do is we can go and put a stimulator onto the spine, the area around the spine, which then sends a signal above the pain signal. So then actually the brain does not interpret the pain signal because it's receiving another signal from the stimulator. And other things that we can do is medications. We can work with different types of medications. We can work with anti-inflammatories, working with different kind of medications to see kind of the multimodal approach with the injections, but all with the idea of hopefully we can decrease the opioid consumption or opioid need. Next slide. So some of the conditions that, we're treating, the number one, what we saw with disability caused is back pain. We look at herniated disc. With the herniated disc, a lot of times if we can get in there when it's acute process and be able to do that epidural steroid injection, sometimes we get great relief in the beginning. We can also look at chronic pain, which helps with some of those nerves when they've had chronic inflammation, just trying to decrease the inflammation with the steroids. That also helps. We look at sciatica. A lot of people, after they've been sitting all day, they can get some inflammation of that sciatic nerve. We can get in there and also use some of the steroids to help with that. We also look at neck pain, and then some other pains that we look at is the nerve pain, which we'll see neuropathy, which some people describe as having, pins and needles down in their leg. Some of the other things that we can look at is musculoskeletal pain, which a lot of times we're seeing new young patients with fibromyalgia or myofascial pain syndrome. And also I'll work with headache pain and cancer pain. And again, all these are chronic pain. And I would like to kind of introduce Eric. I think a lot of times my goal is to be able to help people decrease that pain enough to where they can get into physical therapy and kind of work with physical therapy, because physical therapy with the mechanical changes is what we're going to see for the long-term effect, really being able to help patients with chronic pain. Eric, do you want to talk about a little what you can do with physical therapy?
Sure. Thank you, Dr. Colementor, for including me and physical therapy in with this. But definitely, as far as the team approach, definitely really good for these kind of patients. From a physical therapy standpoint, I do a lot of education on pain, as far as pain neuroscience education. Just telling the patient that I'm going to have them do some movements that are going to be painful, but if they don't understand of what we're trying to accomplish with the movements, then it really will just be kind of button heads throughout the treatment. So education's on the front end, and then just trying to come up with creative movements on chronic pain patients that aren't as threatening. Like you mentioned, pain is basically a protective mechanism, but in these patients, they're almost getting overprotected, and so they're getting pain interpretation prior to any type of tissue damage or irritation. And so if we can educate on that first, while we incorporate movement, that's kind of the biggest thing. If they have any secondary things that are musculoskeletal, we can also treat those simultaneously. But a lot of times it's hard to pinpoint anything specific, like a specific tissue with these type of chronic pain patients, because it's more of a central nervous system problem more so than a specific musculoskeletal system problem.
I agree. I think the importance of really, the lifestyle changes and what we can do, and just offering movement every day, I think is one of the most important things that we can encourage patients to do to really kind of help with pain. I mean, the number one thing we can really recommend is moving your body, and either that be, by gentle stretching at home. They've shown great results with yoga and chronic pain, and also just learning, I think what Eric was talking about with, meditation, and the idea of not being able to control some of those thoughts and be able to maybe down regulate your own sympathetic system. And for you to be able to do that, and it gives the pain patient back some control, which I think is very helpful for the patient. All right. Lauren, is there any questions that we can answer for you?
Okay, so I have some sent in questions. First of all, I did not realize that chronic pain had so much to do with the rest of your body as far as how it affects it and that kind of stuff, because I just thought pain was pain and your body separated the two. Like, you always go through pain no matter what, but it doesn't affect emotions or change the way your brain works and all that stuff. That's pretty cool. So
I think it's interesting, we call feelings for a reason, right? Because we feel them. And then, a lot of patients that I have that come in and they're depressed, and, a lot of them, that's instead of looking to do an intervention, we talk about, depression hurts, and we need to start there before we start anywhere else. Because a lot of times I'll find myself, I could do whatever type of injections, I can do whatever, type of medication for them. But if they don't get a hold and, kind of find themselves in a better spot, then we just kind of keep going in circles, and everything hurts.
That's a pretty awesome way to put it and look at it, because that blows my mind. So I do have a few questions. So just with chronic pain in general, I know that some of them had looked into back pain as you get older, lower back pain, that kind of stuff. But with pain in general, what are good alternatives to medicine? Because a lot of us are trying to move away from medicine if it's not absolutely necessary. I know that at the beginning you had brought up yoga and stretching and that kind of stuff. So what do you usually, especially if maybe we're trying to use it as a preventative, or we're starting to feel our bodies stiffen or creak a little bit more, what are good ways to prevent aches and pains or chronic pain or anything else like that, just in general as we age?
Okay. I think, Eric, this would be a good one for you to take with the, like, just modalities, mechanical modalities that patients can do to help protect their back. I think this would be a great one for you to answer.
So I think the best thing is give the patients the tools to this is what I deal with, especially with chronic pain patients, is giving them the tools for future occurrences. So the most likely, the most common predictor of back pain is previous history of low back pain. So most likely, if you've had some kind of pain in the past, you're most likely going to have that more likely in the future versus somebody that hasn't had pain. And so if you can give them more of the active approach, like Dr. Colementor mentioned earlier, aerobic exercise is really good for people with pain, and educating why. It gets blood flow to the tissue, blood flow to the nerves, and that's what the nerve is kind of thriving on, those kind of movements. Yes, they can be painful initially, but if we educate on the front end of why we're trying to accomplish these kind of movements, as far as me personally, I try to go as active as possible. Some modalities on just for kind of some buy-in stuff with like heat and like stem and stuff like that, to kind of help make it tolerable so we can move a little bit. But the ultimate goal is to give the patient, it's almost like a locus of control. If I can get the locus of control externally, meaning the patient thinks that they have to go to someone else to help them out. If I can take that control and put it internally, that they know, hey, I've had this before and I was able to do this, this, and this, and I felt better. And then that way they're not utilizing the healthcare system as much. And ultimately it's a better quality of life for the patient. And that, so that's kind of my goal. It's chronic pain is a tough thing to treat because this is the patient also has to be willing to accept information that we're giving them, which is sometimes the toughest thing. They might not be to that point yet when they get to me, and that's probably the most frustrating thing as far as personally me is concerned, because I'm trying to help everybody out, and sometimes I just can't help everybody. But you can give them the best information possible, and how they're willing to accept that information is the best way forward.
No, I mean, I think that's great too, because from personal experience, physical therapy after an injury is the worst, but it's pain in a good way. It was totally necessary. I wouldn't have gotten full range of motion back if I didn't do it. So it was totally necessary. But I definitely think that as our generation, our young professional generation gets older and we get settled into our salary paying jobs and our careers and stuff, we forget to be active. And that's when we start feeling the aches and pains and stuff. So I feel like we just need to at least keep moving, whether it's yoga or walking. We need to not stop moving. We actually had a presentation, which was by you guys, by Houston Methodist. And it was how sitting constantly is hurting us. It's not beneficial. So we need to remember as young professionals to keep moving no matter what, whether it's in the morning, the afternoon, park in the back of, the grocery store parking lot. We just need to keep moving, because as we get older, we don't stay as active as we used to in high school and junior high or during college and all of that. So definitely.
Absolutely, Lauren. I think that's the most important thing is really self-care, and I think what happens as you start as a young professional, you're so focused on your career that sometimes that takes over the idea of me taking care of my own self. And I think it's really important just to focus on exactly what you said. If I just need to get out and walk every day just to kind of relax, I mean, movement is the most important thing that we can do for our body and also for our mental health. And, things that we could talk about too to help with back pain is, really continue to work on that, looking at the core, maintaining, doing exercises for the core to help take some of the pressure off that low back. But it's just, if it's just a minute or 2 minutes, exactly what you're saying, you get out, do that exercise, step away from that desk, move your neck, and not looking down at the cell phone or the computer all day, and get outside and just walk for a minute, 2 minutes, and then come back in.
No, I mean, I think that's great advice. And sometimes we just need to remember that. Okay, we have another question. As far as former athletes, and of course, as former athletes from, rotator cuffs or knee injuries or torn whatever, what is something, so how, I guess generally, because I know everything's going to be specific to each patient and all that other kind of stuff, but for the chronic aches and pains that we have based off of that torn rotator cuff or ACL or, broken whatever and that kind of stuff from our high school and college days, what's a good way to manage pain in between doctor's visits or anything else like that? Or I guess, how do you tackle that as we get older? Is there a certain step process if there's not like a general way to take care of that, since it could be anything? Or I guess, what's your advice on that?
I played high school or in college soccer, so I'm an ex-athlete. But I think it's just being aware that, there are going to be some aches and pains. I always tell patients, you're never going to get rid of pain. It may be there, but we just have to learn how to live with it. And some of those things are doing some gentle stretching, sometimes taking some anti-inflammatories to see if it can help. But if it gets to a point where it's inhibiting your quality of life, then I think that's when you need to see somebody about it.
I think that's pretty general, spot on advice, because sometimes it's not terrible enough to where we need to go see somebody, but it's definitely a little inconvenient. So Thank you. I appreciate that. Okay. Do most insurances cover pain management?
Most insurance do cover pain management for the majority of them. A lot of times they will cover physical therapy. I think that's usually, we start with conservative management, and that's usually using some type of anti-inflammatory and then really getting you in to see physical therapy to see if, it's just your mechanics and some modalities that may help you with your pain. And then usually after that, we'll kind of step process, look in to see if we need to do some type of injections, but most of those are all covered by insurance.
Okay. So I have kind of almost a two-part question. It was originally two separate questions, but they seem to kind of fit together. So, and I can relate to this question also. So the migraine process, I know that there was a list in one of the slides, and actually somebody had asked about it before we started everything. The migraine chronic pain process, is that always a trial and test run process, or you as a chronic pain doctor, I guess, how do chronic migraine sufferers approach that? Is it always a neurologist first? And then the second part of the question is, you being a chronic pain specialized doctor, what's the difference, or how do you work with a neurologist and orthopedic and all that other kind of stuff?
Usually we work hand in hand. So a lot of times, the thing with migraines, you want to work it up, and usually the neurologist will work it up to make sure that it's not some type of red flag, something, it makes sure ruling out tumors, ruling out infection, ruling out all those kind of things. And then usually once they've done that, and we'll find out there's multiple reasons for having a migraine, and the two of us kind of work together, then that kind of dictates kind of if a lot of times they'll stay with neurology doing different types of medications. Sometimes they'll be sent over to me because there's a nerve that runs in the back of the head that sometimes is one of the causes for having headaches, that I'll go in, I can do a procedure for that and hopefully calming that nerve down. A lot of times the headaches come from the neck. So once we'll work that up. If we have problems in the neck, then I can go and also do a procedure to help with headaches that are being caused from certain conditions in the neck. So it's the two of us kind of working together. And that's kind of the same thing that also happens with orthopedics. A lot of times it's hard to tell if we have hip pain or back pain. So the two of us will kind of work together. And that's what I meant by that one slide saying things. A lot of what I'm doing is diagnostic. It may be just me going in and numbing a certain nerve to see if you get pain relief from that. or not. And then if you do, then that kind of leads us down the path for one treatment. Whereas if it doesn't, then we have to kind of start looking at something else.
It's super interesting to know, because honestly, I had no idea that doctors like you existed. I always thought it was only a neurologist and only an orthopedic surgeon and that kind of stuff, because I've been through the gamut, and then they'd always send me to a physical therapist. So I didn't know that there was you there helping. So that's awesome. So that's actually all of the questions that we have, but it's also good to know that, you know, doctor, that you are there as like a specialty tool for a lot of specialty doctors and that kind of stuff. It's good to know that we're not kind of stuck with only one option or one path, and that you're there to help. And Eric, as much as I did not like physical therapy, I'm so glad that people like you exist, because it's definitely uncomfortable, but totally worth it when it comes to preventing pain after injuries and that kind of stuff. I wish I would have been a lot smarter when I was younger in high school, when it came to athletics, and listened to them to go to a physical therapist, because now I wouldn't be having issues. But I really appreciate you guys taking the time to go over this. I know we actually have quite a few people who are interested in getting their hands on this footage. I would love to have you guys back, especially talking about some of the things that we went over. As young professionals, sometimes we still hold on to our younger years and don't realize that adulting is sometimes a little painful. So
yeah, I would definitely love, you know, there's a lot of topics that we can deep dive in, you know, especially doing the integrative medicine fellowship. Would love, you know, if we want to talk about meditation, also there's different, you know, we could cover different supplements, and you know, there's all kinds of things that we could do, and different kinds of procedures we could talk about. So thank you for reaching out to us, and you know, it's been a great time.
No, I think that sounds like a fantastic series to possibly look forward to in 2021. I know a lot of our young professionals look for a lot of alternative ways, alternatively to medicine, when it comes to self-care, especially, and that kind of stuff. So anything like physical therapy, meditation, stretching exercises, or supplements, I know that that's going to be super well received. So I will definitely be seeing you guys back in 2021 then.
All right, sounds great.
Yeah, thank you so much. I appreciate it.
All right. Bye-bye.